أعزائي الطلبة, today we talk about the upper GIT bleeding. Learning objectives. First of all, the common causes of upper GIT bleeding. Second, clinical assessment of patient with upper GIT bleeding. And third, management and assessment of severity by Rockall Scoring System. Acute upper GIT hemorrhage is the most common GIT emergency, accounting for 50 to 170 admissions to hospital per 100,000 of the population each year in the United Kingdom. The mortality of patients admitted to hospital is about 10%, but there is some evidence that outcome is better when patients are treated in specialized units. The common causes of upper GIT bleeding, first of all, peptic ulcer, accounting for about 35 to 50% due to, example, H.pylori and non-steroidal anti-inflammatory drugs. Second, gastric erosion, accounting for about 10 to 20% due to, example, alcohol and non-steroidal anti-inflammatory drugs. Third, oesophagitis, 10%, usually with hiatus hernia. Varices, 2 to 9% due to liver disease as portal vein thrombosis. Another cause is Mallory-weiss tear, accounting for about 5% due to retching. Another cause is the vascular malformation, accounting for about 5%. Another cause is the cancer of the stomach or esophagus, accounting for about 2%. And lastly, the aorto-duodenal fistula, accounting for about 0.2% in aortic graft. Clinical assessment. First of all, Haematamesis is red with the clots when bleeding is profuse, or it may be as black or what is called the coffee ground when less severe. Syncope may occur. Symptoms of anemia usually suggest chronic bleeding. Melena is the passage of black tarry stool containing altered blood, usually caused by bleeding from the upper GIT tract, although occasionally arise from right side of the colon. Severe acute upper GIT hemorrhage can sometimes cause maroon or bright red stool. The management. First of all, we have either the cause of upper GIT bleeding, variceal or non-variceal bleeding. So first of all, the management of non-variceal bleeding, intravenous access by large bore cannula, then checking for blood count, routine biochemistry, and the cross-matching of the blood. We start with the initial clinical assessment. We have to know the circulatory status by assessment of the tachycardia, hypotension, oliguria, coldness, sweating, and the agitation. Evidence of liver disease, for example, the presence of jaundice, cutaneous stigmata, hepatosplenomegaly, and ascites. We have to identify any comorbidity, such as cardiorespiratory, cerebrovascular, or renal disease, which may worsen by acute bleeding, and because they increase the hazards of endoscopy and surgical operations. We have what's called the Rockall Scoring System, which is used to predict the severity. It is ranging from 0 to 11, and a score less than 3 is associated with a good prognosis, while a score more than 8 carries a high risk of mortality. The variables of Rockall Scoring System, including the age of the patient, the shock state, if there is any evidence of shock, or its parameters, for example, the systolic blood pressure and the pulse, any comorbidity, the cause of the bleeding, that's mean the diagnosis, and evidence of acute or recent bleeding. So the age of the patient, if it is less than 60, we put the score 0, and score 1 ranging between 60 to 79 years, and the score 2 giving to patient age more than 80 years. The shock state, if there is no shock, we have to give a score 0, and if the patient with evidence of pulse more than 100, we have to give the score 1, and score 2 given to patient with systolic blood pressure less than 100. That's mean the shock state is more advanced. The comorbidity, if there is no comorbidity, we give a score 0, and if there is congestive cardiac failure or ischemic heart disease, we give a score 1. Renal and liver disease given a score 2, while metastatic cancer giving the score 3. Diagnosis, Mallory-weiss and normal condition, that's mean no underlying cause, we give a score 0, while score 1 giving to all others causes of upper GIT bleeding, while score 2 giving to patient with malignancy. Evidence of a bleeding, if there is no evidence of recent or acute bleeding, we give score 0, and if there is evidence of blood in the stomach, we give him a score number 1, while presence of a clot or visible vessel given a score number 2. Other steps in the management include resuscitation, intravenous crystalloid or colloid fluid, and blood transfusion in active bleeding. Low blood pressure and tachycardia is an indication for the need for fluid and even blood. Broad-spectrum antibiotics in suspected chronic liver disease, central venous pressure in severe bleeding. Oxygen should be given for all patients with shock. Endoscopy, this should be carried out after adequate resuscitation, ideally within 24 hours. Recent bleeding can be treated endoscopically by thermal modality, injection of dilute adrenaline, or by metallic clips. Another important point in the management is the monitoring by hourly pulse, blood pressure, and urine output. Lastly, we may have the surgery as a choice of the management. While the management of variceal bleeding, we have to restore the circulation with blood and plasma to prevent further deterioration in liver function because of the hypotension. And second, endoscopy even in patients with non-varices, because about 20% of patients bleed from other cause. Prophylactic, broad-spectrum antibiotics, such as oral ciprofloxacin or intravenous cephalosporin, because sepsis is common and antibiotics has been shown to improve the outcome. The measures used to control acute variceal bleeding include endoscopic therapy by banding or sclerotherapy, or by balloon, tamponade, and esophageal resection. Vasopressin, such as the terpipressine, reduce portal pressure and reduce the acute bleeding and even the risk of early rebleeding. Proton pump inhibitors to prevent peptic ulcers, phosphate enema and or lactose to prevent hepatic encephalopathy, and lastly, shunting surgery by transjugular intrahepatic portosystemic shunting or portosystemic shunt surgery. We talked about the peptic ulcer disease, the learning objectives, definition and pathology, epidemiological characteristic of peptic ulcer disease, understanding of the pathophysiology, clinical presentation, investigations and management and complications. Peptic ulcer. The term peptic ulcer refers to an ulcer in the lower esophagus, stomach, or duodenum, in the jejunum after surgical anastomosis to the stomach, or rarely in the ileum adjacent to Nichols diverticulum. Ulcers in the stomach or duodenum may be acute or chronic. Both penetrate the muscularis mucosa, but the acute ulcer shows no evidence of fibrosis. Erosions do not penetrate the muscularis mucosa. Gastric and duodenal ulcer. The prevalence of peptic ulcer is decreasing in many Western countries as a result of widespread use of H.pylori eradication therapy, but it remains high in developing countries. The male-to-female ratio for duodenal ulcer vary from 5:1 to 2:1, while that for gastric ulcer is 2:1 or less. Chronic gastric ulcer is usually single. 90% are situated on the lesser curvature within the antrum or at the junction of body and antral mucosa. Chronic duodenal ulcer usually occurs in the first part of the duodenum, just distal to the junction of pyloric and duodenal mucosa. 50% are on the anterior wall. Gastric and duodenal ulcer coexist in 10% of patients, and more than one peptic ulcer is found in 10 to 15% of patients. The pathophysiology. First of all, we have what's called the H.pylori. Peptic ulceration is strongly associated with H. pylori infection. The prevalence in developed nations rises with age. In the United Kingdom, about 50% of people over 50 years are infected, and up to 90% in developing world. The infection are probably acquired in childhood. The vast majority of colonized people remain healthy and asymptomatic, and only a minority develop a clinical disease. Around 90% of duodenal ulcer patients and 70% of gastric ulcer patients are infected with H. pylori. The remaining 30% of gastric ulcers are due to nonsteroidal anti-inflammatory drugs. H. pylori is a gram-negative and spiral, and her multiple flagella at one end, making it more motile. This motility allowing it to burrow and live deep beneath the mucus layer closely adherent to the epithelial surface. Here, the surface pH is close to neutral by any acidity, which is buffered by the organism's production of the enzyme urease. This produces ammonia from urea and raises the pH around the bacterium. The bacteria spread by person-to-person contact via the gastric refluxate or vomit. H. pylori exclusively colonize gastric type epithelium and only found in duodenum in association with patches of gastric metaplasia. The bacterium stimulates chronic gastritis by provoking a local inflammatory response in the underlying epithelium. This depends on numerous factors, notably expression of bacterial antigenes or genes called CATCH-A and VAC-A genes, lead to cell replication, apoptosis, increased cell permeability. Host genetic polymorphism are also important. In most people with H. pylori causes enteral gastritis associated with depletion of somatostatin from D cells and increase gastrin release from G cells, which stimulate parietal cell to secrete HCl. The role of H. pylori in the pathogenesis of gastric ulcer is less clear, but it probably acts by reducing gastric mucosal resistance. Non-steroidal anti-inflammatory drugs may lead to impairment of mucosal defenses. So this is another cause for peptic ulceration. Another cause is smoking, which increase the risk of gastric cancer and to less extent duodenal ulcer. Clinical features. Peptic ulcer is a chronic condition with a natural history of spontaneous relapse and remission lasting for decades, if not for life. Duodenal and gastric ulcers share common symptoms which can be considered together. The most common presentation is recurrent abdominal pain with three characteristics: localization to epigastrium, relationship to food, and episodic occurrence. Vomiting in about 40% of ulcer subjects. Persistent daily vomiting suggests gastric outlet obstruction. So vomiting may occur in about 40% of ulcer subjects, but the persistence of vomiting should suggest the outlet obstruction. In 1/3 of cases, the history is less characteristic. So a good percent, 1/3 of cases, the history is less characteristic, especially in elderly subjects under treatment with non-steroidal anti-inflammatory drugs. In these patients, the pain is absent or slight as a vague sensation. Occasionally, the only symptoms are anorexia and nausea, or a sense of undue repletion after meals. So the patient feels a full stomach. In some patients, the ulcer is completely silent. Presentation for the first time with evidence of anemia from chronic and detected blood loss, as or maybe as an abrupt hematamesis or as acute perforation. It may be recurrent, acute bleeding without ulcer pain between the attacks. The diagnostic value of individual symptoms for peptic ulcer disease is poor. The history is therefore a poor predictor of the presence of an ulcer. Why? Because we said that a good percent of patients, a good percentage, about 1/3 of cases, the history is less characteristic, and some cases the ulcer is completely silent, even when there is evidence of anemia because of a chronic blood loss, and in those with abrupt hematamesis, or even those with acute perforation because the ulcer is silent between these attacks. The investigations, endoscopy is the preferred investigation. Gastric ulcer may occasionally be malignant and therefore must always be biopsied and follow up to ensure healing. Patient should also be screened for H. pylori infection by non-invasive test, which includes serology, which is rapid and good for population studies but lacks sensitivity and specificity and cannot differentiate current from past infection. The what's called urea breath test has a high sensitivity and specificity, but require extensive mass spectrometer. Fecal antigen test, it is cheap, specific, more than 95%, but poor acceptability. Or we have the invasive tests, such as the antral biopsy, which include histology. It is sensitive and specific, but it takes several days for the processing, and false negative can occur. Rapid urea test, cheap, quick, specific, but the sensitivity is 85%. Microbiological culture, it is a gold standard and define antibiotic sensitivity, but it is slow and laborious and lacks sensitivity. Overall, breath tests are best because of their accuracy, simplicity, and non-invasiveness. The aim of management are to relieve symptoms, induce healing, and prevent recurrence. So the aim of management is three parts. One of them is relieving of symptom, another aim is healing, and lastly, preventing the recurrence. H. pylori eradication is the cornerstone of therapy for peptic ulcer, as this will successfully prevent relapse and eliminate the need for long-term therapy in the majority of patients. H. pylori eradication, all patients with proven acute or chronic duodenal ulcer disease and gastric ulcers who are H. pylori positive should be offered eradication as a primary therapy. Treatment is based on proton pump inhibitor taken simultaneously with two antibiotics, either amoxicillin, clarithromycin, or metronidazole for 7 days. Success is achieved in over 90% of patients. Side effects of H. pylori eradication therapy include diarrhea, mild Clostridium difficile associated colitis, flushing and vomiting when taken with alcohol, especially metronidazole, nausea and vomiting may occur, abdominal cramp and headache, and even rash. Second-line therapy for patients who remain infected after initial therapy. After 2 treatments, the choice lies between a third attempt with quadruple therapy, bismuth, proton pump inhibitor, and 2 antibiotics, or long-term maintenance therapy with acid suppression. So usually we have to use the first line, then second line therapy, and usually this given after a period. If there is no success, then the third attempt may be done, or we have to use a long-term maintenance therapy with acid suppression. Co-prescription of a proton pump inhibitor along with the non-steroidal anti-inflammatory drug is advised, but is not always necessary for patients being given low-dose aspirin in whom the risk of ulcer complication is lower. Other indications for H. pylori eradication include, we have either definite or uncertain or not indicated. The definite indication including peptic ulcer, H. pylori positive dyspepsia, and in patient with maltoma. Uncertain in family, if there is evidence of family history of gastric ulcer, non-ulcer dyspepsia, long-term non-steroidal anti-inflammatory drug users. Not indicated in gastro-oesophageal reflux disease and in asymptomatic patients. General measures: cigarette smoking, aspirin, and non-steroidal anti-inflammatory drug should be avoided. Alcohol in moderation is not harmful, and no special dietary advice is required. Maintenance treatment: not necessary after successful H.pylori eradication. For the minority who do require it, the lowest effective dose of proton pump inhibitor should be used. Surgical treatment indication include perforation, hemorrhage, complications, for example, gastric outflow obstruction, recurrent ulcer following gastrectomy or gastric surgery. The complication of gastric resection or vagotomy, including what's called the dumping, which mean a rapid gastric emptying, leading to distension of the proximal small intestine as the hypertonic contents draw fluid into the lumen, leading to abdominal discomfort, diarrhea after eating due to autonomic reflexes. So this leading to flushing, palpitations, sweating, tachycardia, and hypotension. Patients should therefore avoid large meals with high carbohydrate. Bile reflux gastritis is another complication. This is usually asymptomatic, but dyspepsia can occur. Symptomatic treatment with aluminum-containing antacid or sacral fate may be effective. Diarrhea and maldigestion usually occur 1 to 2 hours after eating due to poor mixing of food in the stomach with rapid emptying, inadequate mixing with pancreatic secretions, reduce small intestinal transit time, and bacterial overgrowth, all these leading to malabsorption. Diarrhea often respond to dietary advice to eat small, dry meals with a reduced intake of refined carbohydrates. Antidiarrheal drugs such as codeine phosphate 4 to 6 times a day or loperamide after each loose stool. Weight loss due to small gastric remnant in addition to diarrhea and mild steatorrhea. Anemia, iron deficiency. However, B12 and folic acid deficiency may occur, but it is less common. Metabolic bone disease due to calcium and vitamin D malabsorption. Gastric cancer due to hypochlorhydria, gastro-duodenal reflux of bile, smoking, and H. pylori infection. All these are a risk factor. However, endoscopic surveillance is not indicated following gastric surgery. Complication of peptic ulcer disease itself. First of all, perforation is more common in duodenal than in gastric ulcer and on the anterior wall. Abdominal pain start in the upper abdomen and rapidly become generalized. Shoulder tip pain may occur, but recurrent epigastric pain is uncommon. In at least 50% of cases, an erect chest X-ray shows free air beneath the diaphragm. 50% of cases. Gastric outlet obstruction may be caused by fibrotic structure from duodenal ulcer, edema from ulcer, carcinoma of antrum, adult hypertrophic pyloric stenosis leading to nausea and vomiting and abdominal distension. So the gastric outlet obstruction have multiple causes, including the fibrotic structure, especially in duodenal ulcer, maybe due to edema from the ulcer itself, from the complication by carcinoma, or from the development of adult hypertrophic pyloric stenosis. A succussion splash may be elicited 4 hours or more after the last meal or drink. Visible gastric peristalsis is diagnostic for gastric outlet obstruction. Loss of gastric contents lead to dehydration with low chloride and potassium and raised serum bicarbonate and urea. Nasogastric aspiration for at least 200 ml of fluid from the stomach after an overnight fast suggests the diagnosis. The last complication is bleeding. Thank you very much.